بسم الله. السلام عليكم. راح نبدأ الآن إن شاء الله ورشة العمل الثانية بعنوان برامج الدراسات الطبية العليا وتدريب الزمالة في الولايات المتحدة الأمريكية. أعضاء الجلسة الدكتور محمد العيسى الملحق الثقافي في الملحقية الثقافية السعودية في الولايات المتحدة، الدكتورة سمر السقاف مديرة البرامج الطبية بالملحقية الثقافية في الولايات المتحدة، دكتور ماني عميد الجامعة للشؤون الدولية كلية الطب في جامعة تافت، دكتور فيليب أستاذ مساعد مدير برامج قسم الطوارئ جامعة أيموري، دكتور ليوناردو سواني مساعد مدير برنامج ونائب مدير المناهج في مركز اوشنر للنظم الصحية، دكتور رونالد أميدي الممثل الرسمي للدراسات الطبية العليا في مركز اوشنر للنظم الصحية. راح نبدأ مع كلمة للدكتور محمد العيسى.
السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير جميعا. Good evening, ladies and gentlemen. On behalf of the Ministry of Education, of Higher Education, and on behalf of the Saudi Cultural Mission, I just want to welcome all of you, and also we're going to start this the graduate medical education and residency in the United States. هتكلم عن البرنامج اليوم عن برنامج الدراسات الطبية العليا وتدريب الزمالة في الولايات المتحدة. Our moderator, Dr. Mani, also Dr. Philip, Assistant Professor, Program Director of Emergency Medical at Emory University, Dr. Lionardo Siwani, Co-Medical Director, Lung Transplant, Dr. Ronald Amidi, Head and Neck Surgery, اوشنر ميديكال سنتر. بالإضافة طبعا للدكتورة سمر السقاف المسؤولة عن البرامج الطبية في الملحقية الثقافية السعودية في الولايات المتحدة الأمريكية. باسمي وباسمكم جميعا وباسم وزارة التعليم العالي رحب فيهم جميعا، وأتمنى إن شاء الله لهذه الجلسة الفائدة العظمى لكم إن شاء الله وللجميع. قبل ما نبدأ بس بعطيكم بريف سريع كذا عن الملحقية الثقافية السعودية في الولايات المتحدة. كما تعرفون الملحقية الثقافية السعودية في الولايات المتحدة هي أكبر ملحقية ثقافية سعودية في العالم، لا من حيث عدد المبتعثين ولا من حيث البلد اللي احنا موجودين فيه. أنا مسكت العمل في 2007، كان عدد الأطباء والطبيبات الموجودين كان لا يتجاوزون 10 أطباء. اليوم عندنا أكثر من 1500 طبيب وطبيبة في الولايات المتحدة لعمل الزمالة والإقامة في الولايات المتحدة. استطعنا خلال الخمس السنوات الماضية استطعنا أن نفتح أبواب كان من الصعب فتحها، خصوصا في مجال الطب وفي مجال الزمالة وفي مجال الإقامة في الولايات المتحدة. لدينا الآن أكثر من 204 اتفاقية مع ميديكال سكول وتيتشنج هوسبيتال في الولايات المتحدة الأمريكية. السنة هذه ولأول مرة في التاريخ أكثر من 80 طبيب سعودي وطبيبة سعودية يلتحقون ببرامج الزمالة والإقامة في الولايات المتحدة من خلال الماتش، وهذا طبعا يعتبر تاريخ. كما تعرفون برنامج الماتش في الولايات المتحدة يتقدم له أكثر من 25,000 طبيب وطبيبة. السنة هذه وبحمد الله استطعنا أن نحقق يعني إنجاز تاريخي إذا صح التعبير، وسميناه إنجاز. الملحقية تسعى جاهدة إلى تحسين خدماتها وتقديم أفضل الخدمات بشكل عام، وللخدمات الصحية الطبية الأطباء والطبيبات والبرامج الطبية بشكل خاص. نسعى جاهدين أن نقدم كل ما نستطيع. عندنا قناعة أنكم أنتم the cream of the cream، ولذلك يجب أن يكون حجم العمل وأيضا الجهد اللي يبذل جهد كبير جدا تستحقونه، وأيضا لقناعتنا أيضا أنه البلد في حاجة ماسة لكم جميعا. ما أبي أطيل عليكم، تأكدوا أننا في الملحقية الثقافية أنا وزملائي جميعا نسعى جاهدين إلى تحقيق كل ما تحتاجون إليه لا تترددوا في أن تتواصلوا معنا. الأطباء الموجودين الجدد أو اللي على وشك الابتعاث أو حتى اللي موجودين هناك لا تترددوا في أن تتواصلوا معنا. استطعنا زي ما قلت أننا نفتح أبواب كبيرة من خلال دعوة مدراء البرامج الطبية هنا للحضور في المملكة العربية السعودية، وأيضا دعوتهم في كثير من المناسبات لفتح آفاق ولفتح أبواب جديدة خصوصا في برامج الزمالة. وكما تعرفون كان من سابع المستحيلات أنك تبليس فيزيشن في ميديكال سكول أو في تيتشنج هوسبيتال. اليوم الحمد لله أصبحت يعني ما بيقول من السهولة بمكان، لكن أصبحت عندنا القدرة وأصبح عندنا الخبرة أننا يعني نلحق طبيب أو طبيبة في برنامج الزمالة أو في برنامج الإقامة. مرة أخرى أحب أشكركم على حضوركم. لا تترددوا في أنكم تتواصلوا معنا، لا تترددوا في طرح الأسئلة، استفيدوا من مثل هذه البرامج. الأخوة الموجودين المشاركين الأطباء الطبيبات الدكاترة اللي جايين معنا، مرة أخرى أرحب فيكم ورحب فيهم. ونبدأ الجلسة. الدكتور تجماني هو حيكون المودريتر، وأيضا الأخوان الأطباء من الجهات الحكومية الجامعات اللي حضروا معنا. شكرا لكم وتحية لكم. شكرا.
Assalamu alaikum. Today we'll thank you, Dr. Alisa, for your comments. I will briefly introduce the speakers and give a few remarks myself. Each presentation will be about 25 minutes, and then we'll have time for asking questions, and you'll get answers. So panel speakers are Dr. Al-Sagaf, Dr. Lillianardo Sone, Dr. Philip Shane, and Dr. Ronald Amedy. I'm the Dean of International Affairs at Tufts University School of Medicine, and I did my MD from All India Institute of Medical Sciences in New Delhi, after which I traveled to the United States. And I did my surgical residency at Boston University, and then I did fellowships in nutrition and vascular surgery at Harvard. I was the vascular surgeon in Worcester, Massachusetts, after which I assumed the responsibility of being a CEO of the Fallon Healthcare System. I'm the president and founder of Many Consulting Group and a consultant to the Cleveland Clinic in devising their international strategy. And I spent 3 years as CEO of Sheikh Khalifa Medical City in Abu Dhabi. I want to briefly give you a description of where we are today. We have approximately 9 research scholars, and they were all placed successfully. And if you look at the list of places that they matched in, it is not shabby. University of Missouri, Tufts Medical Center, Mount Sinai Hospital, Tufts Medical Center, Case Western, George Washington, and University of West Virginia. The match for 2013 was equally successful. We have 13 successful matches, one in Bay State, one in St. Vincent Hospital, 6 in Tufts Medical Center, 2 in urology in St. Elizabeth's, and 1 cardiology. This gentleman has worked in cardiology for the last 8 years, and he's got multiple specializations, and 1 in dermatology, and that's pretty good. We have about 90 research scholars, residents, and master's students and PhD students enrolled at Tufts Medical Center and 10 teaching hospitals that we are associated with. What my office does is that we screen all candidates, and we select candidates and assist them with the residency application process. We have a close mentoring program. We follow them. We are available to answer their questions and assist them in overcoming any hurdles that they may encounter. The OIA also helps to the residents to obtain fellowships post-residency, and all of this is detailed in our website, which is newly created, and some enhancements to the website will be available sometime in about 4 weeks. The Saudi Arabian Cultural Mission, we have a very close working relationship with. Dr. Al-Sagaf is the leader of this organization, of the medical organization. Hundreds of Saudi applicants have been placed through her office. The SACM is a very important resource, and you should make use of that. This advisors in SACM work very hard to mentor and navigate a somewhat difficult residency process. I need to emphasize that all you medical graduates should take your responsibilities and the studies with some degree of seriousness, because you are, after all, cultural, professional, and personal ambassadors of Saudi Arabia. And that is important because what you do is important for the people that will follow you. Dr. Al-Sagaf is the director of the Department of Medical and Health Sciences programs in the Saudi Arabian Cultural Mission. She did her MD at King Abdulaziz University and subsequently a PhD in anatomy and embryology from KAU. She was initially the vice dean of female students and a dean at KAU to follow. She is recognized for her contributions to furthering the education of Saudi Arabian citizens, both in Saudi Arabia and the United States, and what she has done is an amazing job. So join me in congratulating her and applauding her. Thank you. Got 50 more. I have Dr. Sone, who's the Deputy Head of School and Associate Professor of Medicine in the Oxner Clinical School, and he's the Vice Chair of the Department of Pulmonary and Critical Care Medicine of Oxner Healthcare System. He did his MD at Louisiana State University School of Medicine. Following internship and residency, he did a Pulmonary and Critical Care Fellowship and Lung Transplant Fellowship at Oxner Medical Center. He's a staff physician, obviously, at Oxner Clinic, co-director of the Lung Transplant Program, and has published on transplantation and sepsis. Dr. Shane is professor and vice chair for education and program director, Department of Emergency Medicine at Emory University in Atlanta. He did his MD from the University of Illinois College of Medicine in Chicago, and internship and residency in emergency medicine also in Chicago at Cook County Hospital. He's currently the director of medicine and residency program at Emory University. Dr. Amdi is the designated institutional officer. He's the responsible person for all residency program, and he's chair of the Department of Otolaryngology, Head and Neck Surgery at Oxner. He did his MD from Louisiana State University, as also he did his otolaryngology training. And for a number of years, he was on the faculty of Tulane University School of Medicine and was a Harold Tabb Professor and Chair of Otolaryngology. He's a Fulbright Scholar, which is something you should all aspire for, and is on editorial boards of several journals, and has lectured and published extensively. So I will now turn to Dr. Al-Sagaf for her comments. Thank you very much.
السلام عليكم ورحمة الله وبركاته. بداية لازم يعني نشكر قائد هذه المسيرة ملكنا الملك عبد الله. يعني لولا برنامج الملك عبد الله, the support of the King Abdullah Scholarship, we will not have this success. And our success in SACM, really, it's coming from the Ministry of Higher Education, Dr. Khalid Al-Angari, all his deputies, and on the top of these, the one who supported me so much to get into this success is Dr. Ieche. I will go quickly through our scholarship. We reach almost 100 scholarship in United States. And you can see the sponsor student and the self-sponsor, and the total is 100,000. These are their distributions in different degree. And the number of students in each state, we have a lot of California, they like the weather there. The number of students also, according to under the 1,500, the lesser. And then the total number according to the disciplines. And you will find that business and engineering is the highest number. Total number of students in different disciplines. I have dentistry and nursing in a very good programs. And by the way, our departments, 20% of our students are in elite school. And these are the total number of states according to the the number of requests that we are doing totally. وصلنا ل 2 million requested and 64% accepted, 27% rejected, and other. This is a general information about SACM. What is NRMB? How many of you knows NRMB? Raise your hand. Good. So you have to work hard and read about NRMB. First of all, I want يعني تعملوا لي تحية كبيرة to the students who match this year and make the history. '83 students. When 2012, they told me that, Dr. Summer, 2012 NRMB, there will be no one outside the match. The pre-match position is so limited. I have only with New York Methodist Hospital and internal medicine and in pediatric. All the students has to go through the match. I was so scary. Shall we make it? Is it a very competitive? Our students are ready. We are working for 3 years to have this achievement. And as you know, the total number of the students going through the match is 29,000. 44% of them are foreigners. But what made me a little bit relaxed is my friend in US. They assure me that they can do it. We have a very good students. And the vice president of the ECFMG, اللي هي الرخصة الأمريكية, the Kingdom of Saudi Arabia, they have the highest number of certified students among all the Arab nations, which is 153. If you compare it with the Egyptian, the proportions, we are hiring the higher proportions according to the nation. Our strategy is to make more and more awareness of our programs. And by 2012, we had more than 100 visits through all the US. Saudi Medical College awareness, all the medical college, they are working with me and with SACM to aware their students, to prepare them for this match programs. More than 200 conference calls with different hospital and university, more than 200 medical affiliations, contract, and a skill of enhancement. We have to make a skills to the students to be competitive and they can go through this match. I like to say it's like a marathon. And the one who's match, they are getting the golden medal because it's long process and they get these medals. The research program, which a little bit enhance our students. I have some of the students last year, they didn't go through the research and they have no single interview. By this year, most of the program directors, they told me, Dr. Samar, you have the best application because the first thing that you are presenting to the program director is your applications. So you have to work hard in these applications. Our future strategy is working with Kaplan, and now they are introducing a new program with Kaplan called the application support, the pre-residency program. It's not only for USMLE, it's not only to prepare your exam, It's also for application support. You have 3 rounds of feedback from program directors. You will have a simulated interview, and you will have live online seminars. Thinking outside the box, we know that it is very competitive in many of our programs. And we are trying to think, and we are to try to convince the medical colleges and the Ministry of Higher Education for the very competitive specialties like neurosurgery, ophthalmology, ENT, orthopedic. Until now, I didn't get any history. But with the plastic surgery, for example, Mohammed Al-Rakan, we signed a contract with Johns Hopkins to be the first resident in plastic surgery. And this is how we make the breakthrough and the history. We have to work with the university, alerting them with the special programs, and we have to create a partnership between medical school in Saudi Arabia and US, and the medical department movie. We are now making a movie that explains to all the US university and school the success story of our students. And we have one of the movie star, Dr. Alina Joharji. We start with her, and we start the journey through the USMLE, through the research, and congratulate her. She get residency in Oshner. Please, my students, you have to read and you have to search, and you have to know what are the keys of success. The NRMB result, how many of you have been read this result? 1, 2, 3, 4. Thank you. حيوهم. These guys will know where are the points of success, because according to what you are seeing here, that USMLE score, step 1, in all of the interview, on all of the how can I pick you? 83% or 82% in internal medicine, in family medicine, in obs and gynae, pediatric up to 90%. They will look at your score. This is the first thing that will come to get you and pick you for interview. Letters of recommendations, and because of that, we say you have to prepare yourself early. If you can go to electives in US, or if you can do research, this is what you give you a US recommendation. Because most of the program director, they don't know a lot of your school. They don't know a lot of your teachers. This year, I have questions from some of our program directors. They said, Dr. Samar, where is Taif? Where is Taiba? Because now we are seeing Taiba and Taif graduates coming to the match. So still we don't know, and some of them, they don't know this university. So we need recommendations, and who are working with. مين اللي اشتغلت معاه؟ مين اللي أنت عمل لك good recommendations for the residency? A personal statement. Please don't say there is يعني لسه قدامي أنا لسه طالب still أنا ممكن أشتغل عليها. No, you have to work on your personal statement. You have to work on your resume. بيجيني resume من ناس مخلصين سعودي board و Arab board. Still you have to work in your resume to present it in the way of US like it, in the way that they like it. They want to see you where your strengths and where are you excelling. Some of the flags coming through the application, most important factor in the match that give us scales. Application was flagged with the mass violations. Some of the students, they violate the NRMP regulations. I have one this year, make a violations, and he will be investigated, and the school will be investigated because انسحب من الماتch. He get regret out of the match. And this is usually they look at it very high. Interpersonal skill. Interaction faculty during the visit. Now you are going to the interview, and they will see when they make an interview, when they ask for interview, they will make some feedback from the current residents. You will meet some of the students, they have been introduced or they have been invited to the dinner or to the lunch, and they regret it, they don't go. So they are going outside of the match process because they didn't know you. So you have to attend all the activities in the interview. The grade of the clerkship and also the USMLE grades. These are our number of affiliation. We have more than 200 affiliations in the medicals, 56 in the dental, and 10 in pharmacy, and we successfully also doing a residency in pharmacy. And these are the acceptance rate we have. You can see between residency in 2011, 2012, and 2013. This is the residency. But before 2013, there was pre-match position. But in 2013, which make us enter the history and write history between US and Saudi Arabia, is all of them going through the match, which is 83 students. Because here I put it 81, 2 of them has been given us after the presentation. Still, we have a number of fellowship and research fellow, and you can follow us on the SACAM website. You will find all the names, all the schools, and where did they match. These are the acceptance by the sponsoring agency, and the higher agency that get accepted is Ministry of Higher Education, the one who is sponsored by MUHI. So, to tell you the story of our story in SACAM, NRMB in the Twitter, if you can follow Twitter, you find that the NRMB, the governmental medical organization, they congratulate us for this awesome result. This has not happened before. The match result في السنين الماضية كلها, in all the history, there is 0 up to 3, the maximum which have been matched. This year we have 83, and I am hoping and I'm dreaming to get more and more by your effort, you are the heroes. You are the one to make the history. And also, we need from your departments, from your deans, from your medical school to give you all the flexibility to get this success happened. We assure you by SACAM, by Dr. Ieche, and especially Dr. Ieche, he has a very famous word that ما في شيء خسارة في الطبيب. كل شيء يا سمر سويه لأي طبيب أنت تشوفيه صح أو يشوف البرنامج صح. So all the success for you, and I hope to see all of you match. ودائما احنا بندعي, صارت عندنا دعوة يعني مشهورة, يا رب يمتش كل الدكاترة.
I would like to invite Dr. Lionardo Swani, please.
First of all, I want to thank SACAM for inviting me to this very important meeting, and I want to thank everyone for the incredible hospitality that we have experienced all week. It's been heartwarming. What I'd like to do today is give you an overview of how to make your application more competitive for program directors. And I want to take a very practical approach for the medical student, take you through the USMLE and the importance of that, letters of recommendation, how you can tweak your academic performance to make it stand out more over another application. Then give you some, again, at the student level, very practical information about how do you meet the deadlines for IRAS, because there are some certain very hard fixed timelines that if you don't meet them, you won't be able to apply that year. You'll have to wait a whole entire year. And then finally, I'm going to review some of the data to support all of the pearls, as we call them in the United States, these pearls of wisdom that I've given you. And that comes from the Program Director Survey, which is an annual survey that the National Residency Match Program puts together, surveys all the program directors of what do you think is important for, 1, to get an interview in your program, and 2, to actually match in your program. What are the factors that you use to select your residents? So I'll go over that data with you. So I want to give you some idea of how we view medical education in the United States. We really view it as a continuum. And actually, you know, in the United States, we have an undergraduate degree program, then medical school, which is considered a higher degree, and then graduate medical education program. And we really feel that the training for a medical career starts in the undergraduate degree level. What are those characteristics that are going to position you to be a good physician much later on? And that continues through med school and then on to graduate medical education. And if we select the right people and we train them correctly, then they're going to become lifelong learners that are going to continue to practice medicine, ask the right questions, go to the literature, and continue to learn. And you can see in the United States, the bottom arrow talks about the assessment process, that we've developed an assessment process that also continues and goes with you for your entire life. So you'll need to recertify throughout your career. It's an incredibly competitive process in the United States. And what this graph shows is that even a U.S. senior who's graduated from the U.S. medical school is not guaranteed a position for graduate medical education. They're not guaranteed a residency spot. Now, 98% of graduates from U.S. medical schools get a residency spot. Others are, the green line is others, which are mostly Canadian graduates. You can see a little bit over 50%. U.S. citizens that train outside of the United States, it's about 50% chance of getting a residency spot in the U.S. And if you're a foreign medical graduate like you in the room today, you see you have a less than 50% chance of getting a spot in the U.S. Not impossible, as Dr. Simon has shown with all the great success of SOCM, but very competitive, and you've got to be ready to compete. If we look at the survey from the program directors of, and this is all programs, would you consider percentage of programs that typically will interview and rank, not just interview, but actually willing to accept foreign medical graduates into their programs, it's only about 50%. So you're competing for a pool of programs that's already half of what a U.S. grad would be competing for. And to make it even more competitive, just to put things in a little bit more perspective, U.S. medical schools are increasing their amount of graduates. So we have more U.S. graduates. We've built new medical schools in the U.S., and most medical schools in the U.S. actually have increased the amount of medical students they have. In my city of New Orleans, the two local programs have increased by about 25 to 30% over the last 3 years in the amount of graduates they're now graduating. And so we have more U.S. grads, but we don't have any more residency training spots. And as you can see here, by 2016, not too far away, there'll be more U.S. graduates than there will be residency training spots in the U.S. unless something changes. And that's mostly due to money. It's mostly about the way we fund our graduate medical education. So if you're going to take a picture of a slide or remember anything, take a picture of this slide, because these are the resources that I use to develop my talk. And they're very, very helpful resources for you. The Careers in Medicine from the AAMC, the Alliance of Academic Medical Centers in the United States, has a very good website to help you get around what type of physician do I want to be, giving you advice, giving you some surveys you can do to try to fit you into what would be the correct career for you. The American Medical Association also has a very nice career page. The National Residency Match Program will take you through the timeline that I'm about to take you on in a more detailed way. And then finally, the ECFMG, which is obviously critical to your residency in the U.S. So I'm not going to spend a whole lot of time talking about the match, but just to note the top point, which is it's a confidential system of ranking and selecting applicants to programs. It confuses a lot of people. It confuses people even in the United States to get their head around how the match works. But I want you to remember that it's a binding commitment, that once you enter the match, you are agreeing that if you get selected by that program, you're obligated to spend at least a year in that program. The match works this way. It basically takes all the preferences of the program. So if my program, I'll give you an example as a case study of how it works. We'll receive about 800 applications for 14 medical spots. We'll interview about 90 applicants for those 14 spots. We'll probably rank about 80, and we rank them from who's the best student, who I think is the best fit for my program, from 1 to 80. Now, you as a student have interviewed in maybe 10 places, and then you need to sit down and think of it the same way. What is my first choice, my top choice, where I would love to go. What's my second choice, third choice, fourth choice? And the biggest advice I can give you about the match is the more competitive the specialty, the more you better rank. And two, if you really don't see yourself fitting in that program, do not rank them, because there will be a possibility that you'll be obligated to go there. Then it goes into a computer system, which is what really confuses everybody. But it's basically then a computer algorithm that tries to match a program's top choice to your top choice so that more people actually get closer to what they want. The match actually helps the students. The application process to get in the match is the Electronic Residency Application Service. It's run by the AAMC, the Alliance Academic Medical Center. I like to think of it as a virtual post office. And now the younger generation can get this analogy. The older people, I'm just going to confuse you right now. But it's like the cloud. It's like the internet cloud. So basically, you apply online, and it stores all your information on the cloud. And when time comes for the interview process or for programs to see your application, IRAS will push your application to all the different programs. And so it's a great advantage for the student. For those who need to apply to as many programs, and that's my advice, you apply to as many programs as you can. With just a click of a button, you can push your application to 100 programs. The other nice thing about IRAS is you can follow your application. You register, you start applying, and then you can check on it to see, are my letters of recommendation in? Is my application complete? Because there are some deadlines when it has to be complete. And IRAS is really helpful in that way. Once you register for IRAS, you create your profile in there. That includes a personal statement, your CV, and your picture. And I have an asterisk next to picture because here's where I see a lot of foreign medical graduates make a critical error. And that is, they don't realize that we are very visual people. And so that first picture of you really makes a big impression. So I've literally had applicants take pictures of themselves in a t-shirt or tank top or look like they just got out of bed. That is a critical mistake. That picture needs to be professional. It needs to represent your professionalism. You should be clean, neat, tidy, preferably wearing a suit. You complete and certify your application online, and then you get to select and push out your application to all the programs that you would like. You need to apply early. I cannot stress that enough. Let's give you another example of our program. We interview 90 applicants. We get 700. We will fill up our interview slots with the first best 90 applicants we get. And after our interview slots are full, we don't even look at IRAS anymore. I'm full. And I know that I'm going to get 14 good residents out of those 90 I'm going to interview. And so I'm not going to spend any other time or resources looking at anybody else. I've got my group to go with. So applying early is key, and that's what these timelines are about. My recommendation is that in February and June, you start really having an idea of what I want to do with my life, what I want to do when I grow up. If it's going to be ortho, I'm starting to prepare. I'm starting to get letters of recommendation. I'm starting to do rotations in ortho to get those letters of recommendation. In June, you obtain your ECFMG token. And then July 1st, IRAS opens, and then you need to register. And one warning about registration is that when you fill that registration page and you hit click, you can't go back and change the information you put in the registration page. So make sure that information is correct once you register. Now, once you register, then you can populate the cloud. You can populate the IRAS application with your CVs, your letters of recommendation through that. And you have time. You have time until September 15th, because September 15th is when the program directors now start getting your applications. So you need to have your application complete by September 15th, because that's when all of a sudden On the program director end, on my end, I'm going to get all the applications. I'm going to look at them. I'm going to filter. I have filter systems to filter out the ones that aren't even worthy to look at. And I'm going to take the top 90, and I'm going to start populating my interview slots. So you can see why this is a very important date. Another common area of mistake or room for improvement is the personal statement. This is critical to your success to try to get an interview. You should have your personal statement reviewed by a faculty member. Your personal statement should be presented in a respectful manner. You do need to accentuate what makes you a good fit to be a physician, but you can't be boastful. And in general, I recommend that you cover these three things. Why am I interested in the specialty? What can I contribute to your program? And what do I plan to do with this training? Your grammar must be impeccable. I've read personal statements that were 5 sentences long in, I guess you can maybe call it English. I'm not sure what you could call it. That application goes immediately into the trash can. If you cannot communicate writtenly, you're not any good to me in my program. And then be careful about plagiarism, because while I do recommend to the students to go online and look at some examples of some very good personal statements, there's a very inexpensive software that will run your or any essay against what's published in the internet. And if we get a high plagiarism match, that is unprofessional, that is dishonest, and that's an immediate, we will never take another look at you. Faculty letters of recommendation are important, like Dr. Sommer said. What's maybe a little different in the US is that some specialties like general surgery really require that you have a letter of recommendation from a general surgeon, from a surgeon. And it absolutely helps to have a letter of recommendation from someone in the United States. That's why those rotations in the US are important, for you to prove to them that you're a good fit, you're a good student, and you're going to be a good physician, and you're worthy of a good letter of recommendation. Research is also important. Remember, I'm looking at a stack this big of applications, and I'm narrowing it down to this big, and I'm trying to decide how to do that. What separates one applicant from another? And research is something that can really separate you from another applicant. But also remember, don't overemphasize your research, because if you put that on your application, you're guaranteed to be asked about your research on the interview. And if you can't speak to your research, then that's going to speak volumes about maybe you are embellishing too much and bordering on the dishonest side. The next couple of slides I'm going to emphasize, and this is probably the two most important slides of my entire talk. So another good picture time. This is what the program directors say from the last interview of what do I consider are the most important factors for choosing applicants to interview. Remember, just to interview, not to enter my program, but to get an interview. And you can see your performance on the USMLE is step one, is the most important factor to getting an interview. You can also see your performance on step two is not so far behind. Look what the personal statement is. It's the third most considered factor. Your letters of recommendation from your specialty is number two. The MSPE is the dean's letter. All U.S. students get a letter from their dean in a very structured format, agreed upon structured format, that basically describes your performance in medical school up to date, and that's what that is. And this one just further brings home that point from the same survey that the majority of program directors, 99% of program directors require for you to pass, and a large majority not only require for you to pass, that require for you to be at a certain level on the boards for you even to be considered. And in fact, that's one of our first screening. When we get those 800 applications, we have a screening tool in the computer that if your board score is below this, we don't even look at your application. It doesn't even make it to the next level. And that's a very effective way, and that's why the board score is so important. It's a very effective way of going from 800 to 150. Now, remember, we were talking boards, very important, USMLE scores, very important. Now look at what the program director said was most important for you to get a position in the program, to actually a successful match. And you can see where are the board scores. It's nowhere in the top 5. What we're looking for here is now violations of the match. If you made, sometimes that's an honest mistake. That's why you really need to understand the process. Your interactions with the faculty during the interview and the visit. And what I want to remind you is that your interview starts the second you call that program and speak about arranging the interview. When they call you to tell you, okay, you've qualified for an interview with us, your interactions with the person calling starts the interview process. And everyone you talk to on your interview day is evaluating you, including the residents. So you need to remember that. Any, coming across as unprofessional or rude or impolite is going to be noted. Interpersonal communication skills, your interactions with the house staff, feedback from the current residents of how you've done if you've rotated there, evidence of professionalism and ethics. Nowhere on how we match people are the board scores. So that's very important. I think that's a concept that a lot of students don't understand. They think boards. Yes, that gets you the interview. That does not get you the residency spot. Your fit within the program does. So I'm going to take you through some data, and I'll wrap up here. So let's take internal medicine, and let's look at some data. These are, again, on a scale of 1 to 5, what internal medicine program directors feel are most important for you to match in their program. Interactions with faculty during the interview, interpersonal skills, interactions with house staff, feedback from the current residents. Look, all consistent with what I've showed for all programs. This is the average board scores to get an interview. And you can see the ranges from about 200 to about 210 for step 1, and the median about 204, which basically means that if you score higher than 210, you have a very good chance of getting an interview in medicine. If you score higher than 240 in step 2, again, you got a very, very good chance, and you can see the median. This is all helpful information that's on the NRMP. What I want you to pay attention to on this slide is the bottom right-hand corner. Percentage of programs that typically interview and rank each applicant group. And what you can see is that for medicine, 72% of program direct survey actively interview and rank foreign medical graduates. So that's a specialty that's very welcoming to foreign medical graduates. Let's talk about general surgery. What's most important to the program directors of general surgery? Again, if you violate the match, you're out. Most important, 4.7. Interactions with faculty during the interview. Do we think the interview is important? Interactions with the house staff, and the other one that the surgeons really like, letters of recommendation in the specialty, 4.5. Again, focus on the bottom right-hand corner, percentage of surgery programs that typically interview and rank foreign medical graduates, 41%. Not impossible, about 50% of the programs will take a look, but it's definitely significantly less than internal medicine. And then you can see the board scores for general surgery are just a little bit higher. The step 1 is about the same range as medicine, 200 to about 220, but you can see step 2 is just a little higher. The cutoff point, if you score lower than 230 on step 2 for general surgery, your chances of getting an interview are very, very slim to none. So as you're making your career choices, you got to put that in the equation. And then finally, let me give you an example of a very competitive specialty in the United States, orthopedic surgery. You can see now the board scores to get an interview are much higher, 220 for step one. If you're less than 220 in step one, you got basically no chance of getting an interview. Same thing for step two. And now, again, direct your attention to the bottom right-hand corner. Only 17% of orthopedic programs in the US are actually willing to interview and rank foreign medical graduates. Now, don't take that as an offense. It is very difficult for a US medical graduate to get an orthopedic spot in the US. It's just very, very competitive. But through programs like SOCM, through the affiliations that SOCM is building in the US, that is getting much, much better. And I think that's one of the big take-home messages is to use programs like SOCM to help you through your application. And then as fallback plans, the other big take-home option I give for you guys is that you need to have a fallback plan. Even the US grads have a fallback plan. I want to do orthopedics, but if I don't get orthopedics, I'm going to do, internal medicine and go into physical medicine and rehab because I like bones and joints. The bottom part there shows where the programs that have the most unfilled spots after both the match and the supplement match called the SOAP that occurs a week later for those unfilled spots. And that includes internal medicine prelims, family medicine, and surgery prelims. So if you want to say, what are my best chances? I want to turn the odds in my favor. Those are your best chances. And I'll leave you with that, and I know we'll have questions at the end. Thank you very much.
Salam alaikum. I want to thank Dr. Samir for this invitation. I'm humbly very pleased and excited to have been invited here. I'm going to take you through practical steps in the timeline for getting into residency. A little bit of repeat, a little bit more of some of the inside information that we use as we go through the process. The last slide, I have my email address, and I'll be happy if anybody wants to send me an email to send you a copy of this presentation so that you have the information and the data. So what I want you to get after this 20-25 minutes is an understanding of what these steps in our process are for applying and getting through the application process for getting a residency position in the US. Transmitting your application, how you select where you're going to send it to, getting that interview and how to prepare for it, what this rank list is and how to submit it, and then the process of what the match and the SOAP are. We've gone through this a few times, just another graph to illustrate how difficult it is to get a residency position. The green line are the number of applicants for residency positions in the US. The purple line are the actual number of spots. And you can see that the number of applicants far exceed the number of spots. This is why SACOM has performed such a great service for the Saudi applicants, because they've provided a pathway that's outside of this that creates positions specifically for Saudi applicants. This is the path. We've talked about it, but I just wanted to show you graphically, and I'm going to refer back to this. Submitting your application, this electronic application that goes in, is just the starting of a pathway that gets you to residency. You have to get an invitation for an interview, you have to do well on your interview, you have to rank your programs, and then end up in this match, and we'll go through these steps. Here's the same timeline just to show you how the year is organized. Your ARIS application, you can start entering the information July 1st. It's due September 15th. Technically, you can submit it for 6 weeks. In reality, everybody submits their application on the first day. If you're a week late, you're not going to be considered in a timely manner. So you need to be prepared to have a clean application ready to submit on September 15th. So then the programs, spend the next 6 weeks, 2 months going through them and deciding who out of those numbers we're going to select for an interview. October through February is our interview season, where you're coming. February 15th, you are going to submit your list of where you would like to end up. That's what we call the rank list. 1 month later, roughly March 15th, you get an envelope in the mail, electronically or in person, that shows you where you ended up. We've gone through some examples. This is the non-SOCM pathway to get into my program. Just to give you some sense, we got 1,300 applications. We have 19 spots in the match. So it's about a 1 in 68 chance of getting a position. If you're selected for an interview, your chances improve dramatically to 1 in 12 to get a position. Here was our SOCM pathway. So as you see that for those physicians that Dr. Samar is sponsoring, your chances are still very competitive, but obviously much better with a 1 in 16 shot. So we got 32 applications from SOCM-sponsored physicians. We interviewed 12 of them. Of those 12, we ranked 7, and we took our 2 best. So you need to first apply wisely, because it's really important to get those applications. We've looked at this data already today a few different ways. Let me slice it a little differently. First of all, you're going to apply to the programs that you feel that is a correct specialty for you. And choosing your specialty is going to really count on 2 things. First of all, your preference and your aptitude towards a certain specialty. You may be more procedural based, you may be more cerebral based. But also, you're going to have an honest conversation with somebody about your competitiveness and the competitiveness of the specialty that you're interested in getting into. And competitiveness has to do, obviously, with specialties. The surgical subspecialties are very, very competitive. But it also has to do with the prestige of the school or university, so that a family medicine at a Harvard program, it will be much more difficult to get into than the same specialty at my own university, which is a top-tier university, but not in the same league as Harvard. You might want to consider the location of where you're applying. Residency is tough, and the area you're in has a lot to do with how well you survive it. So you may want to consider big city versus small and where you're more comfortable. Support. It would be wise for you to end up in an area where there are other Saudi students, whether the physicians or not, so that there's a support community. Certainly if you've got family in the United States, it's good to be somewhere close, because residency is hard and you're going to need that support. You may want to consider climate. You may have romantic notions about snow, but if you've not lived in snow and experienced a 9-month Chicago winter, you may not realize that that's not going to be the best place for you. And then funding. You have an enormous advantage. You have an enormous advantage through SOCM because you have positions that are designated for you, and I would strongly urge that you'd apply to those affiliated programs that they've set up for you. So you submit your application, you've done your best, hopefully that you get the interview. What our previous speaker spoke to, what I'm going to reemphasize, is that the interview is critical, that your application, your electronic application gets you in the door. In the US, your interview gets you the position. Let me just say that another way. If you're my resident, every patient you touch, I'm touching, and you're representing me. And so I need to trust you and know that you can relate to them. And this is very personal. So the interview is, for us, a critical part of the application process. You've seen these graphs. This is the only one that I'm using, but just to re-emphasize, this is the what program director said was the most important aspect in deciding who they were going to take at the end. And I know you can't read all that, but just to emphasize, of the top 4, 3 of them have to do with the interview. Your interview and interaction with faculty, your interpersonal skills, and your interview with the residents. So this is our, so I'm going to just give you the same advice that I sit down and give my students from Emory every year about how you approach this interview. and what the practical steps are, because this is a high-stakes game. So, if you've submitted your application and you're invited for an interview, first of all, the minute you get the invitation, the interview has started. How fast you answer the invitation, how courteous you are to the staff member, who usually has a lot more power than you may realize, how you make your arrangements, all the things around it are part of the interview process. It's not just the face-to-face time. So just remember that all your interactions from the day you receive the invitation are important. Be prepared. It's very upsetting to me if somebody comes, they've spent a lot of time and money to come to my program, and I talk to them and it's obvious they haven't read our website. This is a problem with US students who take it for granted that they know what it is, and it's a problem with naivety sometimes. But don't ask me a question that you could have researched, and it's very easy for me to understand immediately who prepared for their interview and who has not. Be on message. You have a story to tell. You need to explain to me who you are, why you're here, and why I want you. You need to have thought about that in advance. It needs to be simple, and you need to be sure that you've repeated it. This is not an innate skill. Also, be positive. Don't say, I want to come here because I don't like the other people. That's a negative message. You don't say, for instance, that you think that training in the US would be better than in Saudi Arabia. It'd say anything negative about your home. You would say, you're hoping that I can offer you additional advantages. Be sure you put a positive face on it, because negative comments in an interview reflect on you much more than they reflect on who you're directing them at. Be professional, and this has not been a problem at all. I find for our Saudi applicants, they're very professional. But this is not the time to experiment with a new loud tie or some fashionable dress. You want to look like a business person and show me that you know how to act like a professional. The worst moment in an interview is when the person interviewing you runs out of questions or gets tired. So you need to be ready to come in with your own questions and be able to take off the interview and lead. So have some questions prepared, so that when you come into the interview, you can direct it or help out if things lag. In America, we're used to this. Smiling and that personal interaction is very important. I find for some of our international grads, they're nervous. It's not a normal situation for them, and they can come across as not as friendly as we know that they can be. So you need to work on your smile. And then just a few words on the interview etiquette. Arrive early. Cities are confusing, medical centers are confusing. Spending a lot of money to come to a new city and then showing up late for your interview. It might be good to have the taxi take you the day before so you know your way around. Dress professionally and conservative. Respond early to your invitation. Pay attention. Every interview is going to be the same. First, they give a little presentation about why you want to come to our university. So you've given you the answers. Then they come and they ask you, why do you want to come to my university? If you didn't listen to why I told you you should want to come, then you don't know how to answer the question. So don't spend so much time thinking about what you're going to say that you miss what they're telling you is important to them. Do not eat. This is a little tricky because people want to be hospitable and they're going to be giving you food and laying it out, but you don't want to be stuck interviewing something with somebody in your mouth. So just politely defer, save the food for later. And then you want to follow up with a nice professional email note. Emails are okay, but emails don't look professional. A nice business card is actually nice, and it doesn't demand from me a response. So that's just a few practical tips on how to get through this, what may be a very American process. So then you've gotten through the interview. You can't get a spot unless you've interviewed there. And let's say you've had the fortune to interview at 10 or 12 places. That's where we get to this process that we've talked about called the match. And I think this is, again, a fairly unique American process. But it's meant to be very, very fair. You will submit a list. It's your wish list, it's your dream list of the programs that you've interviewed at, from 1 to 10 or 1 to 12, however many are, the order that you would like to be accepted. The programs submit their list of their interviews. You never see their list, they never see your list. They go into a computer, it's due in the middle of February. In the middle of March, we have a day we call Match Day, which is a big celebration at every medical school in the US, where every student gets an envelope. If you're not there, you get it by email. You open it up and it tells you where you want to go. That is the match. A few tips. Your list is private. It's meant to be your wish list. If I'm number 2 on your list and somebody else is number 1, I will never know that I was number 2, and it doesn't hurt your chances of getting into my program. So even if number 1 is a place that you're pretty sure you have no chance of getting into, your chances are not hurt. You should, by putting it higher on that list, because the algorithm is meant to favor the student. The rules are very strict. There should be no promises. Nobody should call you up and say, I will rank you number 1 if you put me on their list. It's meant to be unencumbered. There's no private deals. You can express interest and say, I love your program. You just can't say, I promise to rank you number 1. And the purpose is to give everybody a fair chance. It is a very, very fair process. You've seen some of these numbers before. I won't go through it line by line, but just again, this year, 4,000 programs had 29,000 positions. Of those, 28,000 were filled in that match process. So there was about 1,000 positions left over with 9,000 or so applicants that did not get a position. So then that goes into what's called the SOAP. So the first round is the match. The second round, how we try and fill the rest of the positions, is the SOAP, Supplemental Offer and American Program. You see Americans love acronyms, as you do. The SOAP is a 1-week process where we try and fill people who didn't, this is almost your last chance at that go around. And there you have the option of trying to reapply to anything that's left open. And it's a 1-week computer match dating service. This year, of the 1,000 positions, over 900 were filled within that. So after that week in March, there's literally nothing left. So your whole chance of getting a residency slot, whether it's SOCM sponsored or not, is in that week with the match and when the SOAP is done. So that's our process. Your application goes in, you wait for an interview. If you get the invitation, you take it very seriously, you prepare, you do well. You then rank your interview slots, and your chances of getting the residency position are in the match and the SOAP. Just a couple of tips based on my experience of having had some SOCM graduates now in our program. There is so much paperwork you have no idea to become licensed, credentialed, US tax work, human resources. Start immediately and plan to be in the US early to settle and get paperwork done that requires your physical presence. And get some rest, because I'm sure, like here, residency is hard, and you will need to catch up on your sleep for the next 3 years. How to be successful in residency. I have one of my future residents here. He's going to get this speech in a few months. I give all of my residents on day 1 a blank travel log to use as a diary during their journey through residency. But on page 1, I make them write down these 6 or 7 rules of how to be an excellent resident. First of all, if you take good care of your patients, you will always be right. You need to take good care of yourself, because a tired, unhappy physician is not a good physician. You need to take good care of your colleagues, because they're going to have unexpected emergencies. You're going to have unexpected emergencies. You need the good faith of the people working with you to help you get through them. You're going to have a secretary who is the most important person in your life for the next 3 to 5 years. You really need to take care of him or her. Keep up on your administrative requirements, because they would balloon if you don't. And always remember what the goal is, that you will work hard, but you will come out with the ability to take excellent care of people. And that's why you go through this. And you will become the most important person in people's lives when you have these skills. So let me just summarize. Be sure you have your application ready early. Apply to a lot of programs. Be sure that you understand your competitiveness versus the match. Take the interview very, very seriously. Make your rank list a dream list. And if you are lucky enough to match and you've got it, start all the paperwork very early. Here is our success stories at Emory. We're very delighted to have been part of this program, and we look forward to them returning to the kingdom and becoming our own legacy here of excellence in emergency medicine. We'll save questions for later, but as promised, here's my email address. And if anybody would like me to send them a copy of this presentation, I would be delighted to do so. Thank you.
So it is a pleasure to be here this afternoon, and I thank SOCM for the opportunity to participate in this important workshop. We've heard this afternoon from two speakers. The first, looking at residency match process in the United States, perhaps from the perspective of an applicant. And in the last presentation, we heard about the residency acquisition process from the perspective of a residency training program and a program director. It's my job in the next 20-25 minutes to share the perspective from an institutional level, and specifically from the perspective of someone who oversees GME enterprise at an independent academic medical center. I'd like to know a little bit about the audience that I'm speaking with, so if you don't mind, I'm going to ask two very brief questions. Could I have a show of hands of anyone in the audience that is currently in residency or fellowship training? 1, 2. Are you in Saudi or in the United States? In Saudi, okay. How many of you are Saudi medical students aspiring to obtain a residency, and specifically a residency in the United States? All right, now I know who I'm talking to. Great, perfect. Let me share some institutional data with you. We've heard a lot about test scores, Step 1 and Step 2. On this particular slide, what I'm sharing with you is a national mean for the match in 2012, representing some of our core programs at Ochsner Health System in New Orleans. And on the far right-hand two columns, you're looking at the mean of the applicants that successfully matched into our training programs. And if you look at the first three specialties, internal medicine, pediatrics, and OB, you'll notice that the Step 1 and Step 2 scores are kind of close to what the national mean is, but they're a little bit below, perhaps. And you might say, well, why did those people get in? If you take nothing away from the presentations and from this workshop today, a successful match in a U.S. residency really comes down to your ability to communicate, and specifically to communicate in a very professional fashion at the time that you are offered an interview. One of the other things I would like to say in line with some of Shane's comments, we see too many foreign medical graduates that apply to our programs, and it's the only program that they apply to in the United States. So if you're interested in internal medicine, for God's sakes, apply to 10, 15, 20, apply to maybe 50 programs. Leo would go so far as to say in internal medicine, apply to them all. Therefore, you're casting a broader net and increasing your potential to obtain interviews. Interviews is your foot in the door, and it's your opportunity at that point to display your communicative skills, your strong interpersonal skills, your desire to train as a resident in that program, and to hopefully win it and secure that job. I've been a program director for 25 years, a chair of a department for nearly 20, and very active in GME leadership for the better part of the last 20 years. And I'd like to share with you my own perspective on what I see as the attributes of an ideal resident. So when I'm sitting in the room getting ready to interview you, this is what I'm trying to take out of that encounter. I'm looking for applicants and people to match in our program that are professional. And by professional, I'm also emphasizing that in our entire discussion, which is going to be about you, about your interest in the program, but somewhere in that discussion, we're going to start talking about why we are really here. It's to take care of patients. The patient is the focus of our entire educational encounter. It's the focus of our entire professional career. I'm looking for someone to display knowledge to me, not just test scores that are very, very high and exceptional, but I'm looking for someone that has a sense of analytical knowledge and some common sense. Common sense is very important in terms of surviving the rigors of training programs. I'm looking for demonstration of those strong interpersonal skills. So effective communication is important, but at the same time, someone who is an effective listener. Strong eye contact through interviews is very, very important. It shows that you're listening. It shows you're in tune, you're on with what is happening at the moment. I'm looking for someone as a resident from my program who values working and learning in teams. This is my first time to visit the Kingdom of Saudi Arabia, and I had the opportunity to visit several institutions during the past week, and it's fairly clear that in many centers, residency training is occurring in a silo, and it's a very individual type of approach to patient care. What you will find in the United States, which is 180 degrees opposite to this philosophy, is that everything is conducted in a team. And sometimes, as a physician, I'm actually captain of the team. But on any given day, I'm a participant in the team, and I may not be the leader. But do not ever underestimate that even though I am not the captain on that day for the patient, the strong communication, the strong skill set that I'm going to bring to advance that patient's care is incredible. And remember that our teams in the United States are not just physicians. There'll be nurses, there'll be allied health professionals, there will be pharmacists on the healthcare team, and each one brings a unique skill set, which is important to us, learning to function in a team and to providing outstanding care for our patients as part of that team effort. I am looking for practice-based learners. Practice-based learners. What does that mean? I'll give you an example from an ENT perspective. If I have a resident in a room with me as we are going through the evaluation of a patient, and we encounter a neck mass, for example, what have we learned through that particular encounter? And more importantly, the next day, when that resident and I encounter a patient with yet another neck mass, but in another location, what did we learn from the previous day's experience that's going to make the patient before us today better cared for, have a better outcome, a more expedient throughput in the healthcare system? Final thing is, I'm looking for someone that is willing to participate in system-based practice. System-based practice. Again, it goes back to being a member of the healthcare team. What do I bring to the team today to improve healthcare for the patient before me? And what does the team and other entities provide for me so that I can do the same? That's system-based practice. That's also the value of working and learning in teams. So at Ochsner, I can give you my perspective from an institutional view that the goal of Ochsner GME today is to prepare you for the practice of medicine in the 21st century. We're looking for folks that will value team-based learning and coordination of care, and it's the goal of your 3, 4, 5-year residency training program, or whatever it is, to come away with this skill set. The second thing is to learn how to function in a very complex care system. One of the other things that this past week has taught me as I've gone through various facilities here in the kingdom is that there are many institutions that represent very complex healthcare systems. I thought our healthcare system at Oxford was complicated. Some here are even more complicated, but complicated in a good way, complicated in quality metrics and safety metrics that are advancing patient care every day. One of the things you will come away with from training in the United States, and I suppose here also in the Kingdom, is meaningful use capability in terms of documenting your patient encounters utilizing an electronic medical record. At our institution, there's no more paper. Nothing is done on paper. We write no orders, we write no prescriptions on a paper. An ink pen is pretty much useless. A computer terminal, extremely valuable. Everything is documented in that system. And it's very important, and it's been shown that once you achieve meaningful use of a medical record in an electronic format, patient care actually advances. It gets better. Quality improves. One of the essentials of learning in the United States in a residency training program is a better understanding of the affordability of care. There's a lot of things we would like to have, a lot of toys we would like to have in our offices and in our operating rooms, but can we afford it? Can the patient afford it? And finally, one of the things that's essential now in training in the United States is that you learn the science in a residency training program of how to perform and interpret performance improvement, quality improvement, and patient safety initiatives. It is a critical part of the learning process in the United States GME. Leo showed this slide earlier, discussing the continuum of graduate medical education or medical education in the United States. I think this slide is useful anywhere in the world. And I'd like to call your attention to the top arrow, which shows a constant line of learning through that medical education continuum. The learning that occurs prior to the time you enter medical school, all throughout medical school, all throughout residency, all throughout fellowship, and then as you transition to practice, your learning does not stop. God willing, you will learn for another 30, 40 years until you retire from the practice of medicine. The other arrow I want to call your attention to is at the very bottom of this slide, assessment. Particularly in the U.S., GME is all about assessments. Some of those are done very formally on a twice-a-year basis. Some of them are done monthly. Some of them are not done formally at all, but what we call feedback on the fly. Here we are at the bedside of a patient. We're interpreting their findings today. We're interpreting their lab values and their x-rays. And I'm giving you feedback on your ability to assimilate all of this to come up with a strategic care plan that will advance this patient's care. That's not formal. It's not coming in writing, but I'm telling you, you did this part really good and you can improve in this part. If that's something you're not willing to be participatory in, U.S. residencies are not going to be a good place for you to train. We are now going through a renaissance, an evolution of GME in the United States. And actually, July 1st of this year marks the beginning of what is referred to as the next accreditation system. Hopefully, what is going to come out of this is less processes for program directors like Shane and for DIOs like myself. And what is going to evolve and come to fruition in the next few years is more emphasis on competency-based medical education. This particular slide is not all that complex. If you think about the majority of this audience being students, so you're involved in the upper left-hand corner in terms of physical diagnosis and clerkships, and you can see that on that part of the graph, you require a lot of supervision in what you do in terms of providing care. And you also have very little authority in the decision-making of patient care. But you can see that in this continuum, as you complete your internship, your residency, your fellowship, and you transition to practice, you have moved along this continuum to where you require very little, if any, supervision. But now you are responsible for all of the decision-making parameters of patient care. For the last 10 or 11 years in the United States, the majority of our evaluative process, our assessment process of residence and training, has centered on the left oval, the 6 core competencies. And we visited a few medical centers since we're here where we got very specific in terms of goals and objectives of residency and fellowship training, and it utilized these same competencies in some way, shape, or form. What is happening in the next accreditation system is that as you progress through the continuum of medical education, from undergraduate to graduate to transition to practice, we're actually going to introduce some additional competencies, what Dreyfus referred to as a conceptual model of knowledge acquisition, where as a medical student right now, you're probably considered a novice or maybe an advanced beginner. And as you acquire your training in residency and fellowship and transition to practice, we're going to move you along the Dreyfus scale to become not only proficient in the care of patients, but eventually expert and master. The ACGME, our accrediting body in the United States, refers to this particular slide as the GME envelope. And so here you can see the years of training, for example, in a surgical residency, 5 years of respective training in that specialty. And how through those 5 years, as you acquire more knowledge, as you acquire more competency, you will progress from that advanced beginner to become competent in your specialty. And by the time you complete your residency training, you will not just be competent in the specialty, you will be proficient at a minimum. So the continuum of medical education, as I mentioned, involves undergraduate, graduate medical education, and ultimately your transition to practice. This is the continuum. The GME envelope is going to be assessed along the way utilizing milestones, which I'll talk about in just a second. But again, it is getting us from very process-driven residencies. What do I mean by that? 2 weeks ago, yesterday, the accrediting body came to my institution to accredit our institution. That required 6 months of work. The submission of a 700-page document that talked about our successes in GME over the last 5 years. That's an example of a process-driven accreditation process, very laborious. We're looking backwards. What we need to be doing is looking forward. We need to have less paperwork. We need to be spending more time in the field educating and mentoring you as our residents in the training programs. So one of the things I can tell you in residency training in the United States, expect and value lots of feedback on your performance. And hopefully all of this will be done in a constructive fashion. When you start your training programs in the United States, you will be given goals and objectives for the program, and goals and objectives that are specific for each year of training. It is your responsibility as a trainee in the program to not only meet these goals and objectives, but to strive to exceed them. As mentioned earlier, we value a work-life balance, and as a resident, it becomes increasingly important for you to value this also. There is life outside of the hospital. There is life outside of the clinic. There are family responsibilities and other social responsibilities that are very important, and equally important ways to relieve the stress, but never losing the focus on what's before you, learning and caring for patients as part of a healthcare team. Finally, one of the things that I can tell you in this process, again, valuing the science and learning about the science. It's something that is not taught typically in the United States in medical school curriculum. The science of performance improvement and quality improvement and patient safety. Because once you transition to practice and ultimately you get board certified in your specialty, at least in the United States, every 5 to 10 years you will have to recertify. And part of that recertification process is called Maintenance of Certification Part 4, MOC 4. And what you're tasked with doing as part of maintenance of certification is describing a performance improvement, quality improvement, or patient safety program in your own practice. What have you identified as gaps in patient care? How have you gone about filling them? And what were the outcomes in terms of your patient care? So from my perspective, when I'm looking at the continuum of medical education, I'm focusing on the center oval. That's where I spend the majority of my time in terms of evaluating and trying to improve the overall quality at an institutional level for Ochsner, but also at a program level for our 23 accredited training programs, 11 of which are core programs, 11 of which are specialty fellowships, for a total of about 258 residents and fellows in training. I talked about this GME envelope and progressing through the competencies of each year of training, utilizing milestones. Well, what are the milestones? Well, by definition, observable developmental steps which will allow you to progress from a novice to an expert or master in your chosen field of training. As a 30-year faculty member, it's kind of intuitive to us. We kind of know what it is. We don't need to have a definition. I know when you're doing a good job of closing a wound, and I can tell you that. So it becomes a little more intuitive to us, but one of the things that has happened now with the next accreditation system, these milestones are being quantified. I'll give you an example in my specialty again. Our first year of training as an ENT resident, there will be basically 3 milestones. The first one is, can you read and interpret an audiogram, a hearing test? Second, can you evaluate a patient who is experiencing anaphylaxis as a result of either allergy testing or receiving immunotherapy? And the third thing is, can you go to the emergency room and critically evaluate an ENT consultation? Those are the 3 milestones of the PGY 1 year for otolaryngology. That's the 3 things you have to learn, meet, and exceed in terms of your first year of training before you can progress to the second year. Along the lines of the milestones, another component that is being introduced is called EPAs, or Entrustable Professional Activities. I think this is a better way of looking at what milestones really are, because EPAs are real-life patient care episodes, and they're comprised of all elements of the 6 core competencies, so things like professionalism and patient care and interpersonal skills, etc. And really the benchmark of performance is your ability to be entrusted to perform care for a patient without me being there to hold your hand, or in the room seated at another corner, or even being in the building. I have entrusted to you as a resident in training the opportunity, the privilege, because you have demonstrated your competency in this one respective area. So I guess a better way of looking at EPAs through the continuum of graduate medical education is actually shown in this slide. 4 years of training, say in an anesthesiology program, and you can see the EPAs, the evaluable moments of entrustable patient care activities over the GME envelope and how they fit in. Remember that we talked about a lot of assessments, a lot of feedback. That's what training is all about in the United States. And through those particular evaluations, particularly the formal ones, we're going to be looking at the various competencies along this continuum of the GME envelope. And as you can see in black, this is again for an anesthesia resident. We're talking about anesthesia-related technical skills, things like starting an IV, a central line, an arterial line, intubation of a patient. You can see that they fit in this trajectory satisfactorily at the beginning of the PGY 2 year. In terms of system-based practice, and again, in an operating room, that's a very complicated team approach to patient care. Anesthesia, the circulators, the scrub nurses, the surgeons, etc. Again, team-based delivery of care. How do you fit into that? Who do I depend on? Who depends on me to take care of the patient on the operating room table? And you can see those skills in terms of entrustable patient activities come somewhere around the mid-portion of the second year. The green area, patient care or non-procedural skills, what are we talking about? Interpersonal skills, professionalism, ability to communicate. Those are things you bring to the residency on day 1, and you can see proficiency is achieved even from day 1 of the residency. This is the trajectory that we see for our residents in training. I'm using anesthesiology as an example, but across all of our training programs that we offer. Again, a lot of assessments, formal and informal. I'm sorry, this is a busy slide, but you can see a lot of gray ovals up here which refer to specific evaluation tools and how all of these evaluation tools are going to be fed up to what is going to be referred to come July 1st as a clinical competency committee. They're going to consider each resident twice a year. Where are they in terms of the GME trajectory along the GME envelope that I shared with you earlier? So it's fairly clear as an intern or as a junior resident in training, what I have seen through the past 30 years is that you're just usually trying to survive. You're trying to scramble to get work done. You're always trying to go with and hopefully not against the flow. You are immersed in both patient care and very aggressive learning within your chosen specialty. The difference in terms of focus of a senior resident is that you're starting to think about your next move. You're starting to think about the fellowship that you may desire to do. You may be thinking about research you need to complete in order to meet all the requirements of your training program. You might start thinking about getting a job and where that job is going to be. And obviously, there's going to be family issues and other social issues that need to be considered as you perhaps move from one training program to the next, or as you transition from an American residency to your job opportunity back in the kingdom. So that transition to practice, when you finish your residency or your fellowship, typically what folks are choosing to do is enter some sort of private practice. Hopefully, upon your return from a U.S. residency and fellowship, you're transitioning to academic practice in the kingdom. And fellowships may be required post-residency to achieve that. So just one slide on fellowships. What about fellowships? And I think the most important thing I can share with you is that a fellowship is not a form of remedial training. My own specialty, again, if I have a fifth-year ENT resident who comes to me and says, I have not done enough ear surgery, therefore I want to do an otology fellowship so I can become good at doing ear surgery. That's all the wrong reason to do a fellowship. Fellowships in the United States are not for remedial training, but they're for trainees who have innate, God-given talents that I did not give to you, that your program director did not give to you. You came to the program with these skill sets, and they were discovered through the continuum of the training process. And in my opinion, they're devised to take you from proficient to expert and master in a shorter period of time. That's the relevance of fellowship training in the United States. The healthcare system in our country is changing, and it is becoming more collaborative, more team-based, more service-based, more mutually accountable, more patient-centered, and obviously a lot more transparent. This is occurring now. When you join us for residency training in the future, you will be a part of this transformation that is occurring, this new culture that is developing in the United States. I'd like to close with just a few slides specific to the institution that I represent today, Ochsner Health System. And when we are looking at physicians to hire for our practice and for our health system, when we're looking at residents and fellows to come and train with us, we are thinking of them in terms of how they might fit into what we refer to as the Ochsner way. Our health system was founded in 1941 by these 5 gentlemen. And at that particular time, they aspired to create, they came from an academic health center, by the way, and they aspired to create something different. They desired to create a multi-specialty group practice, which in the United States in 1941 was heresy. It was unheard of. It was destined to fail, according to their colleagues. But what they put as their 3 most important objectives is to provide superb medical care, best care delivery of each patient, and balance and temper all of this with excellence in education and research. So graduate medical education, medical student education has been a part of our substance, a part of our fabric at Ochsner since our founding in 1941. And we reinforce what our founding fathers described in 1941 each and every day by serving others. serving others. And again, the patients, their families, and our colleagues. This is it. And again, the patients are at the apex of this triangle, as you see. This is our founder, Alton Ochsner. It's where the name came from. He was a very gifted general surgeon, one of the first scientists in the United States to link lung cancer with cigarette smoking. And I never had the opportunity to meet this gentleman. He died before I arrived at Ochsner. I only wish I'd have the opportunity to sit down and have a chat with him over a cup of coffee. But he said this in the late 1970s, that the modern institution of healing must be permeated with an atmosphere of consideration, courtesy, and kindness, not only toward the patient, but toward his family. This is something that we do. This is something that is in our fabric each and every day. And if you aspire to train at an institution like Ochsner, it will also become a part of your fabric. So the Ochsner way is really simple. It comes down to delivering a great patient care experience every day for each patient that we're privileged to meet and treat at all our locations throughout our healthcare system, and that's provided each and every day by every member of the healthcare team. It's been a privilege to be here in the Kingdom for the last week. I've enjoyed my time tremendously. Thank you very much for the hospitality. And what I'm doing right now is I'm looking into the eyes of the future of healthcare in the Kingdom. From my perspective, it looks quite good. Congratulations.
بسم الله. السلام عليكم. راح نبدأ الآن يا أخوان الأسئلة. راح ناخذ سؤالين من الأخوان وبعدين سؤالين فوق من عند الأخوات. راح نوجه الأسئلة للدكاترة.
Thank you very much, first of all, to all our speakers. I would like to thank Dr. Mohammed Al-Issa and Dr. Samar particularly for everything you're doing. We're really proud to see everything being achieved by SAC. My question is, what is being done regarding those specialties that are extremely competitive, for example, orthopedics and neurosurgery and ENT? So, because during the course of the speeches, we've seen that some specialties have only 3 positions that were filled. So, is there anything? I'm saying that is there anything being done regarding the top specialties, that the most competitive specialties in the United States regarding Saudi applicants, such as those that have been done in general surgery and internal medicine, because it's easier for us to match into medicine and general surgery than it is in orthopedics or in neurosurgery, for example. So, are you doing something to get this, a bit easier, make it a bit easier for us to compete in those higher specialties?
The answer to your question in brief is yes, we are. And in particular at Ochsner, one of the things that we have done in the past year, it's our first year, so it's new for us, but we actually went to the accrediting body, the ACGME, specialty by specialty at Ochsner, to find out if we could increase our resident complements. We didn't tell them why we were going to increase our resident complement. In order to increase a resident complement in the United States, you have to have enough faculty, enough patients to learn from. Everything needs to be in place in order to justify that increase in complement. We were granted initial approval in internal medicine, anesthesia, and radiology, and we plan in the next year to go back for general surgery and OBGYN. Now, those increases in resident complement in the internal medicine program alone was 27 positions. That's over the next 3 years. Those positions are just for the elite candidates from Saudi Arabia. We're not going to fill them with other students from the United States. Those positions were created for one purpose alone, to give you an opportunity to match into one of our programs. Now, it's our first year in this. Okay, we have 5 people that are coming July 1st to join our training programs. But we're going to explore this year by year, and we're going to look for those opportunities to increase the complement in other more competitive specialties, as you have talked about, to give an advantage to you from the standpoint of the more competitive residencies, orthopedics, ENT, neurosurgery. And as we have gone around the country and interviewed students like yourselves, those specialties come up pretty common. We've heard a lot with emergency medicine. Unfortunately, we don't have an emergency medicine residency at this time. We've also heard quite a few students that are interested in neurology. We're in the process of launching a new neurology program. So the discussion for us has just begun. It's rather new, but this is a unique process that was created with you in mind. So,
All right.
you know, we're going to go on this journey.
Yes.
All right?
Dr. Alsagav?
Also, we have successfully signed a contract with Johns Hopkins in a plastic surgery, and we are trying to reset up with the MUHI, changing some of the regulations, because as you know, it's very competitive. When you go to the competitive programs, you need to have a lot of publication. Most of them, they are senior staff, and most of the applicants from Saudi Arabia are juniors. So we are taking the agreement for have more 2 years of research fellow in the very competitive programs. Every year, really, every year we have a new announcement. Every year we have a new things to give up to our Saudi applicants. Before 2 to 3 years, we don't have anesthesia, we don't have emergency, we don't have obs and gynae. And year by year, we try to develop new affiliations. And with you guys, with your preparation, with yours, to be very well competitive, I hope that we can do this history.
Are there any questions from the balcony?
Yes, I was very happy to hear you speak about the multidisciplinary approach, patient-based, evidence-based methodology of teaching that you are advocating at the present time. I have a feeling this is an important issue. It gets all people on board. Accountability, as you mentioned, is very important. During residency programs, is there an effort to get the different specialties and disciplinaries to integrate vertically and horizontally, whether you're speaking about clinical pharmacy, PharmD, nursing, allied health, nurse, medicine, dentistry? What are the efforts done in that field? Thank you.
Dr. Sohn?
I'll speak to medical school since I'm associate dean of a medical school. I can tell you in the U.S. it's been identified that we have for years traditionally trained in silos of nursing school over here, medical schools over here, and then once we get to practice, we had to mix and work as a team, even though we hadn't worked as a team up until then. Now, recently, I just saw, I was at the AAMC, and there was a concerted effort by the AAMC to integrate medical education into teams, including medical students and nursing students and pharmacy students working together. They showed a slide. Currently in the U.S., about 60% of medical schools have some sort of curriculum that are involving nursing and pharmacy and medical students working together. Now, most of it is still in the didactic early stages of the training and not really in the team-based, taking care of patient level of the training. So that will be improving on the medical school side in the years to come, with many innovative projects currently going on. I'll let you guys talk about graduate medical education.
Other questions?
So how many members of the faculty or members of the staff are there in the audience? Anyone? It's a small number. Any other questions from downstairs? Please. Yes.
Yes. My questions to Dr. Shine, please. You just reported out of 19 physician home get matches in your program. 2 of them were affiliated by SACM. I mean, with the new policy of all in, all out, what's the advantages they carry if they were affiliated by SACM? My second question is, on a CV, which one is carry more or valuable more? Spending a year or 2 years on research, even without having publications, or spend a period of time trying to have hands-on exposure with the patient or contact? And is there any way to obtain externships nowadays, or there's no more? Thank you.
So there are a few questions there. In order, let me just say that we have 19 positions for the whole world, plus 2 additional ones for the SACM. So actually our SACM applicants are not competing with the rest of the world. Of the 19 positions, the vast majority of those are going to go to US graduates, but all the other international medical graduates who apply to my program are competing for those positions. And the positions that Dr. Samar has negotiated with us are completely separate. They're not taking away anything. They were additional. They're not resented by anybody. They're totally additive. And they're purely for qualified physicians from Saudi. Your second question was about the relative importance of different types of experience in getting into a residency. There's no easy answer for that, but let me say it's more the quality of the work that you do, whether it's in research or clinical experience, and the quality of the applications, than it is the amount of time or what it is. And so a record of achievement, record of success is much more important than what it is that you do. And if you find something that you find relevant, applicable, and that you love, that would be the best thing to devote your time to in preparing your application.
There's a question over here. Yes.
First of all, I would like to thank our distinguished guest and speaking for sharing the barrels of wisdom. I graduated from fellowship in the United States. I finished in 2010, and I wish I had similar talks when I was applying back in 2005 and 2006, when I was sailing in the dark and trying to do this out of the SACM. So sincerely, thank you. The second thing I witnessed during my fellowship is the enormous job and the transformation that was done in the Saudi Arabian Cultural Mission, SACM, to open the doors and invest in the medical graduates. And for that, I would like to thank Dr. Samar and Dr. Ieche for their effort and their hard work. I have a question for Dr. Samar. Regarding the applicants, most of the graduates that they match, they're mostly from King Saud or King Abdulaziz. Some of the smaller universities or the recently established universities, I would think that they need more support, especially they don't have the coaching or the mentoring. And I think you should give those universities some priorities if possible.
Thank you, Dr. Adil. I want to thank all the staff that they are here, because really this presentation is very important to the staff to guide and mentor. And I want to thank King Saud and King Khalid, I'm not sure with others that they are coming. We are working together. We are working with all the universities. And usually my famous word is please mentor and advocate and advise your students and prepare them before they come. As NRMB is a big applications, and we create with our with the US university, the friendly university, that we create the position for SACM. And when you go to the NRMB, you can find SACM track and you can apply to the SACM track. And by the way, you can apply as Dr. Philip Shen and other doctors apply to every program. It's not only SACM. You can apply to any positions. But according to the acceptance rate, that means most of the students in MUHI, the list is higher than the others, not because the candidate is not good or because of the candidate, maybe of the flexibility of MUHI. We are the mother and father of all the students, but the parents actually. But because when we have these students in our pool, when they are coming here, when some of the soup vacant positions, I can send mass email. So who is there? The one who is there is MUHI students, the demonstrator or assistant or teacher assistant, maybe they are in Saudi. If you can, I remember I have 3 demonstrators, they are not in US, and they match. They are King Abdulaziz, I think, demonstrator, and one from King Saud. They are outside of our pool, but we give them they were in the scholarship for 1 year and they came back, but they apply. So we are help anybody, we can help anybody. But because the MUHI students are within our pool, are within our connections, any information is ready for them, within second we get this position, it's within second go to everybody. And they are flexible. demonstrator, if there's general surgery, as Dr. Shen and other, Dr. Roland, I say, you can apply, if it is general surgery is so competitive, you can go to internal medicine because there is vacant. Demonstrator cannot do that. They have to go through one channel. More student, I have some of students, they were dreaming to be general surgery, and now he's family medicine and so happy because he get that. And also some of them in anesthesia and psychiatry. By the way, it's hard work. You need to have a hard work. But sometimes I have some story which is, I cannot say how this one is successfully do it, but ممكن هذا توفيق من الله. He get one interview and he get match. And other have 12 interview and they didn't get in match. So sometimes application, interview, and all the process that you are going all above that, توفيق من رب العالمين. وإن شاء الله زي ما قلت يا رب كلكم بتمتشوا. Any questions, please? We have our guests in the booth. You can ask them, and I can give your emails. Anybody ask about their emails, I can send it to you.
One last question from the balcony, please.
Okay, I'm a last year medical student from King Saud University, and I want to thank you all about this interesting presentations. I get a lot of benefit from it, and I just want to ask about radiology residency program. How many students you usually accept, and where do you advise me to apply?
Radiology?
Yeah, radiology residency program.
We have one radiology, Lena has been matched in Oshner.
Radiology falls, if I'm looking at the more competitive programs versus the least competitive programs in the United States, radiology falls toward the end of the spectrum of more competitive. So their test scores, their metrics for the match are fairly high as compared to, say, a resident applying for training in family medicine. So it's a fairly competitive residency out there. There's a lot of physics, so hopefully you like your physics, or you did very well in physics as you took it, because it's a very important component of training in radiology.
I have 2 students has been matched, as I remember, 2 females in radiology, and I will, if you follow us in SACAM website, by the 1st of July, we will add all the students that had been accepted in which school and which specialties. But please follow up in our website.
And I think we have some students in Tufts too,
Yes,
radiology.
Tufts,
So we have over 200 agreement with the medical school and teaching hospital. So this is really gave us opportunity to place a physician everywhere in the United States.
Last question with regard to the plastic surgery and the Johns Hopkins affiliation. Would you please kindly provide more details with regard to that?
The plastic surgery affiliation is the first one in US. Nobody have these affiliations. We agreed with Johns Hopkins to have the students for 2 years in research fellow, and then they will create a SACAM track, and they will, all the Saudi graduates will compete for these positions. And by the way, we also have some of the students in the 5th and 6th years have been interviewed this event to get them into research fellow and elective to be prepared and to know them and have recommendation even before they start. You have to have also high score. As everybody showed to you, the specialty become more competitive, the score become more higher. Yes, it's continuous, yes, 6 years.
For plastic surgery, if you would allow me just to answer. There are 2 programs. First thing, the student program. We'll host the students for 2 months in order to make sure that we choose the appropriate one to enter our 8 to 9 year program. There will be 2 years of research fellowship. During the first year, the candidate will be, of course, evaluated. Once he passed the evaluation and he goes to the second year, automatically he is guaranteed a residency spot in the integrated program at Johns Hopkins. Well, in order to apply to our program at Hopkins, for the first year, you'll have to have at least USFLE Step 1.
Any research position, usually any research position you will offered by SACAM, and we have a lot of research fellows, you have to finish step 1. You cannot do both together. This is my advice. Finish your exam and then apply.
Well, I want to thank all the members of the audience, and I also want to thank all the panelists for their comments, and have a good day. Thank you.
The Saudi Arabian Cultural Mission, represented by Dr. Mohammed Al-Isa, would like to thank all the guests for their time, and please, if you can accept our appreciation. يا اخوان، اذا اي احد عنده اي سؤال او اي استفسار، لان لضيق الوقت اضطرينا ننهي الجلسه. ركن الملحقيه الثقافيه في المعرض، انا والاخوان كلنا موجودين هناك. اذا في اي استفسار او اي سؤال، اهلا وسهلا في اليوم وفي بكره ان شاء الله.